Hello, everybody, my dear friend online. This is Nanjing First Hospital, the second live case, TAVI case. The first on behalf of Professor Xiaoliang Chen, I'm Dr. Junjie Zhang. On my right side, I introduce my team, Dr. Hongxiang Quan and Dr. Ye. And today's moderator is Dr. Gao Xiaofei. Today, our live case is a TAVI case for severe bicuspid aortic stenosis. And today's our echocardiographer image doctor is Dr. Zhang Quan. So first, let me introduce our case. This is a 74-year female presented with a repeated dyspnea for 1 year. This patient has quite a lot of comorbidity, including essential hypertension, diabetes. 12 years ago, the patient suffered from heart check and treated with stenting in LAD and diagnosed with a two-stent technique. And I think more than 30 years ago, the patient suffered. Okay, this patient this time will suffer heart failure, and echocardiograph issue is a typical severe aortic stenosis with a bicuspid valve. So the STS score calculated is up to 8%. So it's a quite high risk patient for surgery valve replacement. So decision was made to perform TAVI procedure after discuss with this patient and his family. Next. Next slides, please. So actually, yeah, you can see this is a baseline TT echo. It's a typical severe aortic stenosis. And also, actually, you can see there is a severe calcification due to the bicuspid valve. And also, you can notice, maybe from TDE not so clearly, you can see it's right and the left cuspid fusion with a calcified carina. Next. And the next slides, please. Actually, you can see from the 4-chamber and 3-chamber view, you can see the high-speed velocity across the aortic valve, and also the LV vacuity is quite small, and there is no aortic regurgitation. Next slides. Okay, you can see according to the calculations, it's a typical severe aortic stenosis with a normal LV function, without any aortic regurgitation, with a very small LV cavity, with I think a mild mitral regurgitation. So next. So actually, this is a baseline CT analysis. I'm not sure my dear friend can see this CT analysis. You can see it's a typical right and left cusp overlapping with a severe calcified carina. And according to the CT analysis, the aneurysm diameter is 22.4 millimeter. And in terms of coronary height, it's high enough, and also the cusp flap is large enough. There is a low risk of coronary obstruction. So next. So this is a coronary high, both the left and the right coronary is high enough, more than 50 millimeter. Next. So in terms of peripheral artery disease, the both sides of the femoral or iliac artery is large enough, more than 7 millimeter. So according to the peripheral CT scan, we decided to perform the right femoral puncture. Next. So according to the echo and the CT analysis, decision made to perform TAVI for this particular bicuspid aortic severe stenosis with a general anesthesia, and considering its BAV case, so decision was to perform a TE-guided TAVI procedure. So according to the CT analysis, 23, the domestic Texas Torus valve, self-expanded valve was decided to use for the TAVI procedure. That's all our baseline information for this patient. So actually, let me introduce what we have done now. Actually, this patient is under the general anesthesia, and we puncture the right femur and with a two-pro glide suture device. And now we can show what we have done now. So first picture. So before procedure, actually this patient has a PCI history of 12 years ago. So you can see we performed coronary angiogram. The right coronary is nearly normal. Next, this is the left coronary angiogram. For LAD, it's a typical LAD and the diagonal two-stent technique. The stent was patent. 12 years ago, treated with two-stent technique. I'm not sure what technique this patient was used. Maybe a culot or maybe a crash standing, but never way the stent was patent. So next, this is LAO cranial. Stent was patent. Next. So this is aortic root angiogram. You can see there is a very eccentric classification. For the non-conslap, actually the leaflet was a motive, minimal classification. For the left side, because it's a typical BAV case, left and the right conslap was fusion with a calcified terrain. You can see there is a lot of calcium. So there is a minimal aortic regurgitation from the aortic root angiogram. So this is what we have done, and we also insert a temporary pacing wire from the right carotid jungle veins. So so next step, I think the T is already. So I would like Dr. Zhang Juan to introduce this patient's today's T result. So please, Zhang Juan, introduce.
Thank you, Prof. Zhang. Actually, this patient's TTE imaging is quite suboptimal because of the patient have got the right side pulmonary ectomy. So the heart was pushed into the right side of the thoracic. So,
pardon, can you show the echo, technician? Can you show our echo? I'm not sure. Okay, sure.
Okay.
Go on.
So, but in TE, we can definitely say this patient is a bicuspid aortic valve, and the open area or orientation is about 7 to 9 o'clock. I think this is the most difficult type of the bicuspid valve to do the TAVI, because the open area line is horizontal. So actually, we can see there is a heavily calcified raphe in the anterior side of the aortic valve. This means the fusion of the right and left cuspids. So I'm quite worried about the calcification, because it is very indicated the PVR. This means peak perivalvular leak after the TAVI procedure. So let's move to the lung axis view. Actually, the bicuspid aortic valve is quite calcification, and the movement is quite restrictive. And there is no aortic valve regurgitation. So the left ventricular cavity is quite small. So I think it is indicated the high demand for this procedure. So if there is PVL or severe aortic valve regurgitation during the procedure, the heavily hypertrophy small airway maybe cannot tolerate. So the annular diameter use the 3D maneuver we calculated is about 68 millimeters. So that's all for this patient, Prof.
Thank you. Thank you for the introduction of Professor Juan. This is a very tough case. Very early gentleman suffer from severe aortic stenosis and heart failure. CT analysis and TER find bicuspid aortic valve. Professor Juan, I have several questions for you. We all know this is your team, the fourth live case on TAVI in Medstream 360.
Yeah.
All these four cases were bicuspid aortic valve. Would you mind explaining why so many bicuspid aortic valve in China?
So I think the Asian population. So there is some disease difference during the right side and the western side of the world and the eastern side of the world. So actually, as my echo study, there's for the aortic stenosis because of the bicuspid valve. The bicuspid aortic stenosis occupy roughly about 20 to 30% of the population. So we study from the January, it's only 2-3% of the Western country. So in China, I think it is 10 times of the bicuspid valve compared to the
Welcome everyone. So we are presenting our first case, an 88-year-old male with hypertension, type 2 diabetes mellitus and atrial fibrillation treated with rivaroxaban. In the echocardiogram we observed 31 millimeters, an aortic peak velocity of 4.4 meters per sec and an aortic valve area of 0.77 centimeters. The STH score is 3%. In the EKG, we see an atrial fibrillation with left anterior fascicular block. The laboratory tests were normal, and the coronary angiography showed a severe lesion in the mid-right coronary artery. The femoral angiography and the CT scan show good caliber vessels without significant lesions. And in the cardiac CT scan, we observe an annulus diameter of 23.5 millimeters with a perimeter of 74 millimeters. The coronary height is 8 millimeters to the left main and 15 millimeters to the right coronary. The total Agatston calcium score is 673. The device chosen is the Allegra 27
patient. Maybe it is presented with heart PIF other than heart rate. So in China, there's a lot of people and many people they just reduce the open thoracic surgery. So I think for them we try the TAVI for the high risk patients. Yeah.
Thank you. I fully agree with you. Maybe the money or the customs, a lot of Chinese border patients refused cabbage or sava, and then they choose PCI and TAVI procedure. Professor Zhang, we know you have performed a lot of IHC for heart failure patient. Do you think IHC is very important for TAVI procedure?
Yes, I think it is quite important. Actually, we do a lot of valves procedures in our center. Besides with TAVI, we do MetroClip, something like that. So for each patient, we do the IHC for this patient, for the valve procedure patients. Some parameters in the IHC, for example, the pulmonary hypertension, the PVR, may be indicated the long-term, short-term result for this patient. So this is one reason. The other reason is if the patient combined with the pulmonary hypertension or the elevated PVR, we would do the procedure earlier for them and find some other drugs, typically for the treatment of the pulmonary hypertension and surgery and plus medical therapy. We want to get a good result for this patient. Yeah.
Thank you, Professor Zhuan. I agree with you. And IHC is very important. Sometimes the clinical doctors always ignore IHC, the importance of the IHC. We all know you performed a lot of TE or TTE before procedure, during procedure, after procedure, and a long follow-up, long clinical follow-up for all these TAVI procedure patients.
Okay. Yes.
And do you have any suggestions or parameters for predicting the events, the advanced events, or after the procedure, TAVI procedure? The PVR or the right heart failure, function, and other parameters. Yes. What's your suggestion?
You are very right, Prof. Gao. So before the procedure, when we do the TTE, some signs or some indications can indicate the long-term result, short-term result. For example, if the patient have already have CPC-PH, have already have pulmonary hypertension, the PVR have already elevated, and the most important of is the right side heart function. For example, if the patient has severe aortic stenosis, severe mitral MR, but the right side heart function is okay. So I think after the procedure, the patient can recover very good. But if the patient has already emerged with right side heart failure and right side, for example, tricuspid, severe tricuspid regurgitation, so maybe we deal with the left side disease, the left side valve disease, but the patient, after the procedure, the patient can still suffer from the right heart failure. So the right heart function is one of the important indicated. And the other is the whole situation of the heart. For example, for the stenosis, if the airway is quite small and there is no regurgitation before the TAVI, I think it is really not a good sign. It may be indicated the small airway, the quite hypertrophic airway cannot tolerate the complication situation during the procedure for the regurgitation, post dilation, or the PVR. So I think we should take all these situations totally to decision.
Thank you for Professor Zhuan. We all know you have published a new article about pendant for the type 1 PH patient.
Not so easy.
Yes, Professor Zhang, it's very tough crossing the stenotic valve.
Yeah, actually, you see, I tried to cross the valve. It's not so easy.
Yes. I have a question for you. If you did not cross the valve, what's your next step?
Yeah, actually, it's very rare conditions. I think because the aortic valve is a severe aortic stenosis and also very eccentric. So, and also the non-cath-lab leaf rate is quite high. So it's high speed velocity. Make me very difficult to control precise towards the very small orifice. So the only way we can try, the first I try the AR1 and try 2 wire. One is a hydrophilic wire, another is a coiled wire. Then I considering it's a little dilated aortic root and a little horizontal. So my colleague Dr. Dong suggests me to change the another guiding catheter, M plus left one. Finally, you can see with the right, I think the right catheter and make the tip towards precisely toward the very small orifice of the aortic valve is successfully cross valve with a straight wire. Now I think the next step we will use a pigtail to exchange the wire. So if we still failed after multiple tries, I will actually decide to make puncture the trans left puncture with the anterior method. You know what I mean? I transfer the septal and use a pigtail across the septal and across the mitral valve. Then I will use hydrophilic wire across the aortic valve anteriorly. And just at the ascending aorta, I will use a snare, capture the anterior wire, and then we pull out capture the hydrophilic 300 centimeter wire to pull out to the left coronary or left femoral. Then exchange it with a stiff wire. So it's a integrate method. This is a fight method. But unfortunately, we successfully cross the aortic valve.
Okay, congratulations. This is your final weapon for this tough case.
Yeah.
Yeah.
Actually, you can see the RV cavity is quite small. Dr. Zhang Juan, can you see my picture? It is just at the
Yes, in the left or non-coronary sinus.
Yeah. I try to insert my pigtail into the apex. Yeah, here
is not in the apex.
now I think it is in the apex. What do you think? So at this time, I think echo image is quite important in guidance the wire position.
Yes, we can see it is
Yeah.
it is already in the apex. Oh yeah.
Yeah. So it's
The RV cavity is very, very small.
yeah, you can see from the hemodynamic.
And
there's quite a lot of quite very high gradient, more than 100. Yeah.
Yeah, very high.
Every signaling the apex, the anterior wall and posterior has already casing to each other.
Okay.
Okay. Professor, which wire do you use? You want to advance in the left ventricle?
I think I will super support wire, land quest wire. You can see it's we have shaped wire tip with a small curve, considering the small RV dimension.
Okay, you shape the wire by yourself?
Yeah, it's not a pre-shaped wire. We shape by ourselves.
Yeah, very good. Professor, do you perform pre-dilation for all these EIV patients?
Sure. For this particular case, we definitely will dilate it because it's a very eccentric calcified arena and severe without any regurgitation. So I will do the balloon dilation with the 18 millimeter balloon before I insert the TAVI.
Professor, what's the risk of the pre-dilation?
Yeah, actually there is a minimal regurgitation. So after balloon pre-dilation, we should be cautious for the cardiac collapse. So at this time, I have already set up the valve. And also we will do the hydration for this patient.
Okay, smoothly.
Sure. Okay. 100. 118. up.
Working well.
Sure.
So.
Wow, very eccentric. You see?
Yeah.
Okay. Stop facing. 保存。保存。保存了吗？保存。好。保存。We have do the balloon dilation, and you can see due to the very eccentric calcified arena, the balloon there is during balloon dilation there is a waste. And also the wire tip is not so good. I will still use a pigtail cassette to exchange the wire and make the wire tip at the right position, avoid the injuries apex. Okay. So now the hemodynamic is go up to 80 millimeter mercury. So Dr. Zhang Juan, can you introduce the echo information after BAV?
Well, actually, it is quite a successful BAV, but I think the valves of the leaflets of the valve is quite thickening and quite calcified, and it's very hard to open. So actually, till now there is mild mitral regurgitation. Yeah, but I think the moment of the has already enhancement problem. Yeah.
Okay, I think that's okay. That's okay. We can use this wire.
反流不是特别多，院长。
好的。
有一点点。
好的。There is no severe regurgitation.
Yes.
Okay, it's good.
Yes, okay. The hemodynamic is stable. We have enough time.
Yeah, and also you can see after BAV, the gradient was decreased.
Yeah.
补液加快。加快。
Okay, good. Then we reshape the wire. Yeah.
Okay. The valve, yeah.
For the wire.
The valve.
Okay, now next step we'll advance the self-expand valve.
Okay, Professor, which size do you prefer?
According to the CT analysis, so designed to make use 23 Taurus valve. It's a third generation self-expanded domestic valve.
Okay.
Okay, yeah, 首先行。
Are you selecting the valve size based on the annulus parameter or superannular sizing?
For this particular case, I think I'll still use the annular sizing.
Okay.
怎么了？
早薄比较。那个导师不在半间。
哦。导师小心。
导师不在心间。
导师小心。
早薄比较多。
OK， 好，回到正位处。Go back to IO coils. I think the wire is not in the right position. So at this time, maybe there is difficulty. 我测出来。交换。Advanced valve cross. Advanced TAVI valve cross aortic leaflet. So I will still pull out the valve, and maybe I need to change a new wire.
Yeah.
Now it's okay, bro. Yeah.
准备个新导师。
现在还可以，现在没问题。
老师不在信息。
现在还可以。
支撑不够。
Very strange chef.
So for this tough case, I think wire support is always very important. So I need a very, very good strong support wire. OK， 小心啊。OK，
给个新的。
好。
Professor Zhuan, after the predilation, the relaxation is a lot or just mild?
Mild,
Mild.
mild to moderate.
Okay.
Yeah.
The dynamic is stable, so we have enough
Okay,
time.
yeah.
And
So now I change a new wire and then shape the wire tip, considering very small RV dimension. The tip curve should be very small. With a double curve. Okay, good.那就在新间吧。
在，挺好的，现在。在的，no problem.
RV dimension very small.
Yes.
Yeah, you see. Conscious wire tip. Yeah, now.
圈圈都被压扁了。
Yeah, the RV muscle compresses the wire. You can see.
但是被压扁了。
the movement.
Yeah.
来上，按摩，按摩。
图形抖一下，两边的是。
Now we insert the valve system.
Give you a force.
The wire tip position is good, Dr. Zhang Chen.
Yes, it looks good. Well, yeah.
OK， 孔波你固定啊，别让它出来。看上面。好，看下面。回到对。
走。
可以，好。
Okay.
Okay, we successfully cross the valve, and we will go to the I/O caudal view. 打成一条线，对。孔波把那个3个点打成一条线。That's good.
Yeah,
I think it's good. It's okay. Let's release the valve.
Why is good?
争取0啊。OK， 收一点，再往下送一点，收一点，收一点半膜。OK, good. Up, pacing 100. 放吧，开始。Okay, good. So I will do the high implantation. Okay, let's stop. 噪音。Good. Okay. 120. Continue. Release the valve. 张娟看着啊。
Looks good. Yeah.
Okay, too high?
Not too high. Yeah. From echo.
Okay, good. 继续放。
They're below the annular.
OK， 有点深，140。
还好。
噪音。
还好。
OK, good position.
Good.
Yes.
Good. Release.
到死顶。
不能再浅了。
好，可以。不深。
不能再浅了。
好，可以。
到临界点了吧？
好。
对，可以放了。
OK。
没问题。
Stop pacing. So we release the valve to the recapture point.
等一下啊，这个后方。
Okay, let's take a picture. Awesome. 这还可以。Go to the another view. 回到左前斜。张娟位置怎么样？
位置好的。
How about the position?
The position looks okay. It is 0 position, 0 high.
Okay. Can you pull out a little your
Okay.
your problem? Okay, good. Let's take a picture. 对齐了。
但是后方有点反流出来，可能放完了会好一些。
我觉得位置还可以，相对
蛮好，蛮好。
但是后方有点反流。
I think the position is good, so we decided to deploy it. So still go to the I/O caudal. very, very eccentric. You can see due to the very calcified carina. Okay. 导丝后侧不用再顶了。Okay, now I ask my assistant, my colleague to pull back the wire, release the tension, and pacing 114. 释放。张娟
Okay,
echo monitor
looks good, bro.
120. The position is good.
Yes,
What's the dips?
0 dips.
0?
Yes.
Not sure.
还没放完会好点，小心点，不能再顶了。
不顶。
Okay.
Okay, good. Okay, good.
Yes.
Okay.
Looks good.
Very stable.
We stop pacing.
院长还会过吗？
当然，导丝后侧。
这半夜没打开。
Yeah, I see. 导丝后侧。导丝后侧。好，可以啊，后侧啊。
有些中心性的反应。
好。
但是 PVR 没见到。
Okay. I think the valve was not fully opened due to very eccentric and severe calcified carina. I will do the post dilation.
Which size?
I still use 18 bloom.
18 bloom. Okay.
收回来了吗 ？OK， 好，请马振老师看一下血压。So I will do the post dilation with the 18 balloon.
液体的快速补吗？
要不快速补
hydration 快速补液。
Let's take a picture.
我探头要上。
不用。Is there any PVR? I think there is some regurgitation. Is it central regurgitation or PVR?
From echo, it is central regurgitation.
Okay.
And it looks no PVR. The central regurgitation because of the wire may depress the prosthetic valve. Yeah.
Sure. I think the valve position is quite good, and not so very expanded. So I do the post dilation.
The valve from the short axis is not very wrong.
Yeah, definitely very eccentric.
So not very barely expand.
Yeah,
so
I see.
Post dilation, I think it is needed.
Definitely, it's like standing. We should.
But the valve position, the valve function looks good.
Okay, 118.
And no PVR, and it is very good result for this patient. Okay.
It seems better.
Yeah, now after post dilation, it seems better.
Yeah.
Okay, stop pacing. 保持，不要我提示。
定了，已经定了。
I think now the shape of the valve is good there.
Yes. The position after post dilation is not changed. The valve
Definitely.
is stable, and the valve movement is improved a lot, and the shape from the short axis is improved a lot and quite round.
Okay.
We can see the coefficient line of the 3 leaflets. Yes, Prof.
Okay, can you calculate the velocity and the mean grid for this case?
Go to the transgastric.
Okay, Professor Zhang, I have a question. And what's the risk of the post dilation for these patients?
For this case, I think there is no quite a lot of risk because the coronary obstruction risk is low, and another risk is avoid aortic root injury.
Prof, the maximum quite prosthetic valve velocity is about 1.4.
That's good.
And the mean pressure gradient is, I just measure it out. I think it is normal.
Okay.
About,
so very eccentric calcium nodule, cancer
it is
in
about
carina.
3
So I will use a smaller balloon.
mercury.
I think
Yeah.
80
is
balloon
only
is
3
safe
mercury.
for post dilation. Yeah, avoid the aortic root injury. Another risk, of course, there will be some risk for embolization, especially for the brain. So far is no data. Routine use a brain protection device.
Prof, okay.
Go ahead.
Prof, actually from echo, it is
Let's
a
take
perfect result. And the valve is in the very suitable position. The function is normal. And the most importantly, there's almost no PVR for this patient.
Okay, good.
Yeah, so very perfect. A lateral central rotation. I think when you remove the wire, it is where image. Yeah.
Yeah, I think so. Yeah. So actually, this is aortic root angiogram after post dilation. This looks good. Yeah. And go to the AIO.
It's a new LBBB.
Yeah. And please put out a little the valve, the probe.
Okay.
Okay, good. You can see from the IO to AIO, actually, you can see it's still an eccentric valve deployment. But considering from the echo information, Dr. Zhang Jun introduced the velocity only 1.4, there is no gradient from the hemodynamic. I will not do the post dilation with a big size balloon, considering that the risk of the aortic root injury.
Yeah, I agree.
I think it's good position. Very, very minor regurgitation. And also the coronary is also very patent.
Okay, very excellent result. Professor, how do you evaluate the risk of the permanent post-medic implantation for this patient? The ECG find the new LBBB.
Yeah. I think. Actually, according to data, there is a 40% of cases after TAVI procedure will occur LBBB. And among these left mounted broach patients, I think 60% were recovered. So for this case, I think we do a high implantation. So I'm not worried. For this case, I will continue to monitor. So I think for this case, RBB maybe it will be temporary, will disappear. If not disappear, permanent. So I will, after go home, this patient was discharged, is discharged. I will routinely call back at 3-6 months after TAVI procedure to do the echo and the ECG and the monitor to see is there any high degree AV block. Also, we all know for the RBBB, it's an independent predictor of the heart failure and the of course death after TAVI procedure. So if this patient at 1 year follow-up still RBBB and also QR interval more than 150 milliseconds, and also with RV dysfunction. So as these scenarios, we will consider according to our protocol, our cath lab, we will consider for this patient to perform the left bundle branch zoom pacing to make recover the RV synchronization to recover the RV function.
Okay, thank you, Professor. Thank you for your great experience sharing with us. My final question about for this patient is, this patient has a history of drug-eluting stent implantation 10 years ago, and today he received a TAVI procedure. What's your strategy for the antithrombotic treatment for this specific patient?
I still treated with a single platelet therapy, only with aspirin, because for PCI procedure is more than 10 years single antibladed therapy enough. For TAVI, they consider this patient without any atrial fibrillation, so still follow the guideline recommendation. So aspirin 100 per day, lifelong.
Okay, thank you.
Okay. So I think, ladies and gentlemen, we're close. We completed the TAVI case. So this is elderly females presented with heart failure and with a high risk for surgery. So decision was made to perform a TAVI procedure according to the CT analysis. So this case, there is a 2 point. One point, I think it's a typical BAV case with the right and the left cusp overlapping with a very eccentric, high degree calcium cranial. So for this case, when we cross a valve, there is some difficulty. But fortunately, we successfully cross a valve with a straight wire. Then for this case, we think we should do the BAV predilation because of very severe calcification, very severe stenosis. So for the valve implantation, I think for this case, I would like to choose a self-expanding valve in terms of a safety concern, yeah, because very eccentric calcium. So after valve deployment, according to the valve shape, and also from the echo information, the valve was undeployed. So we do the 80 millimeter balloon post dilation successfully, and the final result shows a gradient was go down to 0, and the peak velocity was only 1.4. There is a minor vegetation PVR, and also there is no coronary obstruction. So this is our case. So thank you very much for your attention. So now I think we will pull out the pigtail from the LV, and we will try to remove the cheese with a blue light. There's no regurgitation?
Yes.
Okay, good. You can see from echo there is no regurgitation. So Dr. Kong will do the remaining step to suture the puncture side of the left femoral. Dr. Kong. So Zhang Jun, I think we still have time. You can introduce the final echo result.
Okay. After the movement of the wire, we can see there's no regurgitation. Very minimal regurgitation, and no central regurgitation. And the position of the valve is quite good. It's almost 0. And from the posterior side, we can see the valve did not impingement the mitral valve, and the mitral valve moment is okay. And from the anterior side, we can see it is only about below the annulus, about 2 to 3 millimeters. And we can see clearly the leaflet of the valves, and the seeing and the moment is normal. And the X-plan, we can see the thorax of the valve is okay. And the leaflet is seen, and the 3 leaflets is corpuscle line is clearly seen. And there's no central or valvular regurgitation. Yeah, I think from my experience, it is February. It is a very perfect result for this patient. Oh.
Okay, thank you for your introduction of the echo result. Thank you very much.